Well, thank you, Dr. Garg, for that for introducing me to the audience. And at the very outset, I'd like to thank the organizers, particularly Dr. Sunil Pandya, for having invited me here and be part of this series of lectures on major obstetric hemorrhage. I must also thank the speakers who spoke ahead of me, Dr. Keman, Dr. Anju, and Dr. Stephen, for having made my job extremely easy. I think you've taken all the difficult stuff and explained all that, and now, as has been requested by the organizers, I have to just talk about something very simple, that is the anesthetic considerations and the postoperative management of a patient who has a major obstetric hemorrhage. Now, as has been told by the earlier speakers, obstetric hemorrhage is the leading cause of maternal mortality in India. And probably the reason, or the combination of reasons why this happens, is that there's a failure to recognize the risk factors, a failure to estimate the actual extent of blood loss accurately, and also a failure to initiate treatment quickly enough. And probably a combination of these three factors is what leads to the fact that maternal mortality is highest in obstetric hemorrhage. Now, again, this has been alluded to by our earlier speaker. Good teamwork between the obstetricians, the anesthesiologists, interventional radiologists, gynecologic oncologists, because in some situations, like the placenta, accreta, increta, and percreta, the invasion has gone far beyond the uterus, and in those cases, we do need the surgical oncologist to step in as well. Blood bank providers, because it's a very specialized area that we're dealing with, and specialized surgical teams need to work together for the success of management of a patient with major obstetric hemorrhage. Now, listed for us here is the various causes for hemorrhage. We've learned this from our medical school days, but I'm going to restrict the discussion of anesthetic management to just a few of these. The anesthetic management of placenta previa, retained placenta, and uterine rupture. Placenta previa, by definition, is defined when the placenta is implanted ahead of the fetal presenting part and can be classified as total, partial, or marginal, depending on how much of the placenta covers the cervical os. Painless vaginal bleeding during the second or third trimester is the hallmark of this condition, and lack of abdominal pain and abnormal uterine tone distinguishes the placenta previa from abruptio placentae. Now, though there was a term called doing a trial of labor or doing a vaginal examination in the operating room in a double setup. Now I think with the advances in ultrasonography, it provides us an accurate diagnosis of the exact location, and that facilitates the obstetrician, the team, to decide between a vaginal delivery and a cesarean delivery. Now, as far as the anesthetic management is concerned, I think we need to emphasize again the need to look at the airway properly and assess the blood loss, which is essentially the reason why this patient is coming up for a cesarean section. We need to evaluate the hematocrit, the hemoglobin, the blood type, and the cross-match, and volume resuscitation must be initiated at the earliest with non-dextrose containing solutions. The choice of the anesthetic technique depends on, 1, the indication and the urgency for delivery, 2, the severity of maternal hypovolemia, and 3, the previous obstetric history. Now, a patient with placenta previa who does not have active bleeding, without active bleeding, or the intravascular volume deficit is not there, can be managed with a neuraxial anesthesia, particularly if the patient already has an epidural catheter in place. But one must remember that when we attempt to do a placenta previa under a neuraxial technique, there is always an increased chance of bleeding because the surgeon may cut through the placental site or through the lower uterine segment, which may not contract very effectively because that may be the site of implantation. And there's a possibility of a placenta accreta, which may complicate the issue. The anesthetist must, on the other hand, be prepared to rapidly correct hypovolemia through 2 large bore intravenous cannulas. And the options for invasive hemodynamic monitoring must be always available. Now, placenta previa with active hemorrhage, where the bleeding has been quite a bit, poses a much greater challenge. And patient evaluation, resuscitation, and preparation for operative delivery must go on simultaneously, and one must reserve adequate blood. At least 4 units of packed RBCs must be ready before we take up these patients for surgery. In the operating room, we should have adequate blood administration sets, rapid infusers for administering blood rapidly, fluid warmers to take care of the hypothermia that can be accompanying, and invasive hemodynamic monitoring should be readily available. Right at the outset, we should have a type-specific blood, or at least type O, Rh-negative blood must be administered while we await the complete cross-match. Considering a general anesthetic, we must use a rapid sequence induction is preferred. And because of the hemodynamic instability, ketamine in a dose of 0.5 to 1 milligram per kilo, or etomidate, which has a better cardiovascular stability, is probably preferred as the induction agents of choice. And the patients are maintained with 50% nitrous oxide and 50% oxygen with very low concentrations of a volatile anesthetic, considering the hemodynamic instability of the patient. As soon as the baby is delivered, we need to make sure that oxytocics are used. Oxytocin in a dose, in a concentration of 20 to 30 units per liter is administered looking at the response of the uterus. And a small dose of opioid like fentanyl or a benzodiazepine like midazolam may be used following the baby delivery in order to prevent maternal awareness, because all the while we are dealing with a patient with hemodynamic instability and we might have been underdosing or giving less of anesthetics. So after the baby is delivered, we now take care of the mother, the maternal awareness part of it, by giving small doses of opioids or midazolam. Coming to the next condition, the placenta accreta, which is defined as an abnormally adherent placenta. The extent of invasion can again be diagnosed by ultrasound, accreta, increta, or percreta, depending upon the degree of invasion. And most of these patients would require surgery and may even require a cesarean hysterectomy, which must be part of our consent when we approach such patients. The preoperative placement of an internal iliac artery balloon catheter or the intervention radiology is very important, and I think Dr. Kamen has covered this in fair amount of detail, because the bleeding can be definitely controlled or minimized when we have the intervention radiologist also being part of the team. The procedure is best performed under general anesthesia, as it is fairly complex, time-consuming, and very often heparin is used as part of the interventional radiology technique, and therefore there is no role for a neuraxial technique in these patients. We must always keep sufficient amount of blood products ready and keep at least 4 units of packed red blood cells and 4 units of fresh frozen plasma in a ratio of 1:1 available in the operating room. And in more complicated cases, the ratio goes up to much more, 10 units each of packed red blood cells, FFP, and platelets, and preferably 10 units of cryoprecipitate as well. In emergency cases, when the diagnosis of placenta accreta is made intraoperatively, the anesthesiologist must initiate what is called the massive transfusion protocol, which initially includes the release of 6 units of O-negative PRBCs and 4 units of AB group FFP. And the blood bank, depending on how advanced they are, should be ready within the next 20 minutes or so to give more blood products. They should be ready to release an additional 10 units of O-negative PRBCs, 10 units of AB group FFP, 10 units of platelets, and 10 units of cryoprecipitate. And we've already heard about the use of recombinant factor 7A, should be available on demand. The massive transfusion protocol must be initiated. And what this essentially means is that we should have a means of administering blood rapidly in the operating room. A rapid infuser must be available in the operating room, and one person from the anesthetic team must be dedicated to the management of transfusion, because a lot of blood products are used and we don't want any problems with administration of wrong products. So we have to have one person of the team dedicated to use the rapid infuser and also make sure that the blood products are properly checked before they are administered to the patient. We must minimize the use of crystalloids and colloids, because this further dilutes the coagulation factors, and therefore we must use blood products as early as possible. And we must use the PRBCs, FFP, and platelets in a ratio of 1:1:1. And when it is done in this ratio, the mixture of a PRBC, FFP, and platelet in a 1:1:1 ratio has a hematocrit of 29%, a platelet of around 85,000 platelets per cubic millimeter, and a coagulation factor activity of 62%. Dr. Anju has also talked about the importance of the levels of fibrinogen. The fibrinogen level of 2 to 3 grams per liter is necessary for adequate hemostasis, and this can be achieved either by using fibrinogen concentrate itself or by the use of 30 ml per kilo of FFP or 3 ml per kilo of cryoprecipitate. Each of these raises the fibrinogen level by about 1 gram per liter, and it's necessary that we bring it up to at least 2 grams per liter so that the coagulation can be adequately taken care of. In refractory cases, one must consider agents such as the recombinant factor 7A, and the dose that is recommended is in the range of 60 to 90 microgram per kilo, or tranexamic acid. 1 gram is given slow IV over 1 to 5 minutes and repeated once every 30 to 60 minutes. Coming to the third condition, retained placenta, defined as a failure to deliver the placenta completely following delivery of the infant, And the risk of postpartum hemorrhage increases significantly when the interval between the delivery of the infant and the placenta the delivery of the placenta exceeds 30 minutes. The anesthetic management is, again, in stable patients, we can use a neuraxial technique, and very often just a sedation with ketamine up to 0.5 milligram per kilo or fentanyl 50 to 100 micrograms may be sufficient for the obstetrician to get the placenta separated and removed. But if the obstetrician requests for uterine relaxation, which very often they do, one may need to take recourse to a general anesthesia, in which case we do a rapid sequence induction of anesthesia. Concentrations of volatile agents such as halothane, sevoflurane or desflurane up to 1.5 MAC values decreases the uterine contractility by around 50%, and the moment we turn off these anesthetic agents, the tone of the uterus returns with the discontinuation of the volatile agent. So once the placenta is separated and removed, we can discontinue the volatile agent and the uterus starts contracting again. The other option of relaxing the uterus is to make use of drugs such as intravenous nitroglycerine in a dose of 50 to 100 micrograms, which produces adequate uterine relaxation. It can be also used by the sublingual route as a spray or as a tablet. Coming to the other condition, uterine rupture, which is hopefully we are seeing less and less of it even in India. It's a complete defect of the uterine wall resulting in a fetal compromise or a maternal hemorrhage. The clinical presentation includes vaginal bleeding, hypotension, cessation of labor, and fetal compromise. And the hallmark of diagnosing uterine rupture is a non-reassuring fetal heart rate pattern, which is kind of almost a very reliable sign of uterine dehiscence or uterine rupture. The surgical options available for uterine rupture include uterine repair, if it's a minor dehiscence, an arterial ligation, or even a postpartum hysterectomy. Again, since the hemorrhage is very massive, one must do a simultaneous resuscitation of the patient while you're preparing for an emergency laparotomy, and general anesthesia is the technique of choice in view of the gross maternal hemodynamic instability. Now, irrespective of the kind of the obstetric hemorrhage that we are dealing with, all these patients need to be taken care of in a multidisciplinary intensive care unit where a team approach involving at least an intensivist and a transfusion medicine specialist would be the best to take care of the complex coagulation abnormalities that we come across in these patients. Now, because of the fact that these patients may have been hypotensive for a long period of time, may have received a lot of blood products, they are very, very likely to develop two complications in the post-operative period, and that is acute renal insufficiency and respiratory inadequacy, and these again are best dealt with by an intensivist in the intensive care unit. So in summary, what I'd like to say is that major obstetric hemorrhage is one of the leading causes of maternal mortality in India, and aggressive volume resuscitation with the early use of blood component therapy is the most important aspect in the management strategies that are involved, and a close communication, a good teamwork between anesthesiologists, obstetricians, intervention radiologists, gynecologic oncologists, blood bank providers, transfusion medicine specialists, and a specialized surgical team is very essential for a successful outcome. Thank you very much.